All right, so you've sent over some really interesting stuff here, digging into something pretty challenging, managing alcohol withdrawal.
It really is.
And for years, the standard approach, it's been benzodiazepines, right?
That's right, yeah.
But this stack of articles, this research you share, it kind of suggests maybe we should be looking seriously at, well, an older tool that seems to be making a big comeback, phenobarbital.
Uh-huh. There's definitely renewed interest.
So in this deep dive, we're going to walk through these sources with you. We'll try to figure out, why alcohol withdrawal is such a beast to manage,
Yeah.
what problems the traditional benzo approach runs into,
Right.
and crucially, why phenobarbital is getting all this attention now.
Yep.
We'll look at how it's actually used, the dangers, really critical dangers to watch out for,
Very important.
and what the latest evidence from these papers is actually telling us. Think of it like getting up to speed properly on a tough clinical problem.
Okay. And, to really grasp why certain treatments work or don't work, we kind of need to understand what's fundamentally going wrong in the first place.
Yeah, what's happening in the brain?
Well, alcohol withdrawal is essentially the brain reacting, quite violently sometimes, when a depressant it's adapted to is suddenly taken away.
Because chronic drinking really changes brain chemistry, doesn't it? It messes up that balance between the calming neurotransmitter GABA and the excitatory one, glutamate.
Exactly that. Alcohol sort of artificially boosts GABA and suppresses glutamate, take the alcohol away suddenly, and you're left with not enough GABA effect and way too much glutamate activity going unchecked.
Ah, okay.
And that runaway excitation, that's what drives the classic symptoms we see.
Right. And those symptoms, they tend to follow a bit of a timeline, I gather, from the sources, though I guess it varies.
It does vary, but yeah, there's a general pattern. You might see milder things first. Anxiety, feeling sick, maybe some mild shakes kicking in around, say, 6 hours or more after the last drink.
Then it can get more serious. The sources mention alcoholic hallucinosis.
Yes, that can sometimes start surprisingly early, maybe 8 to 12 hours in. That's where people might see things or hear things.
But they kind of know it's not real?
Usually, yes. They often have insight, which is a really key point distinguishing it from full-blown delirium.
Got it. And then seizures are a big worry.
Definitely. Typically peaking between 12 and 48 hours. Often they're brief grand mal seizures, self-limiting. But the danger is they can cluster, come one after another, and there's that small but serious risk of status epilepticus, continuous seizure activity.
Okay. And the one everyone really fears, delirium tremens, DTs, that's later.
That tends to be a later development, yeah. Often around day 2 to day 4 after stopping drinking, sometimes a bit later, but usually in that window.
And DTs is a whole package.
It really is. You've got agitated delirium, severe confusion, plus that intense autonomic hyperactivity, heart racing, blood pressure through the roof, sweating profusely, maybe a fever.
And the sources mention something important about the timing there.
Yeah, a really practical point. If delirium starts after day 4, especially in a hospital setting, you really need to question if it's purely withdrawal. It's much more likely something else is going on or contributing.
So you need to broaden the search.
Absolutely.
You said history is vital. How much does that steer things?
Oh, it's fundamental. Probably the most important diagnostic tool you have. You need to know their drinking pattern. Are they drinking heavily every day, or is it more binging? When exactly was the last drink?
Crucial timing.
Crucial. And critically, have they had withdrawal before? Especially have they had seizures or DTs in the past? Because someone with a history of DTs is at very high risk of getting it again.
Right. It's like they're primed for it. So it's real detective work, piecing together their risk.
It really is. And, while getting a blood alcohol level on admission can give you some objective data, higher levels often mean higher risk.
Right.
It's the history that tells the main story. And something the sources really hammer home. DTs is a diagnosis of exclusion. You absolutely have to rule out other serious causes of delirium or agitation.
Like what?
Things like infection, low blood sugar, head injury, maybe drug intoxication or withdrawal from other substances, electrolyte problems. You have to think broadly before you land on withdrawal as the sole cause.
Okay, that makes sense. So that's the challenge. And for decades, the main weapon in the arsenal has been benzodiazepines.
Yeah, they really took over from the 1970s. They replaced barbiturates, which were used before then.
And interestingly, these sources point out that shift wasn't necessarily because of overwhelming evidence that benzos were better.
Exactly. It seems it might have been driven more by a perception of safety, which, as we now know, is a bit more complicated than it first appeared.
Right. And these papers highlight some of the issues, the limitations with benzos.
Well, one major frustration clinicians run into is that they just don't work consistently for everyone. You get patients who are termed benzo-resistant.
Why is that?
Pharmacologically, it makes sense. Benzos don't directly stimulate the GABA receptor. They just make the body's own GABA work better. They augment its effect.
Okay.
So if chronic alcohol use has depleted the natural GABA system or changed the receptors, the benzos might not have enough to work with. Plus, they don't do anything about the other side of the problem, the glutamate excess.
Ah, so they only address half the imbalance, sort of.
In a way, yes,
Yeah.
and their pharmacokinetics, how the body handles them, can be really unpredictable. It's tough to know exactly how much active drug is floating around or how someone will respond.
You mean the same dose affects people differently?
Massively differently. One person might need only 50 milligrams of diazepam total to get control. The other might need 500 milligrams or even more. That makes dosing tricky.
Sounds like you could be constantly chasing your tail trying to get it right.
It can feel like that.
Mm.
And then there's this other risk that the treatment itself causes problems, so-called iatrogenic benzodiazepine poisoning.
The treatment causing delirium.
Yeah, you give more benzos because the patient is agitated, but maybe the agitation is actually from the benzos, especially in older adults or those with other medical issues. One source calls it a looping paradox.
Wow.
They even mentioned a study where patients who were delirious for a long time actually improved when they got flumazenil, the benzo reversal agent, which strongly suggests the benzos are the problem, not the solution in those cases.
That's counterintuitive.
It is. And then there's a practical issue with high-dose IV infusions, especially lorazepam. The propylene glycol used in the formulation can build up and cause toxicity.
Because you might need such large amounts.
Exactly. Patients can end up on what's described as a lorazepam roller coaster, needing frequent doses to try and maintain a steady effect. It often gets complicated, needing multiple agents in a benzo-based protocol for severe cases.
Okay, so enter phenobarbital again. It sounds like it's not just dusting off an old drug, but maybe it has some fundamental properties that actually address these specific benzo limitations.
That's precisely the argument these sources are making. It has some distinct pharmacological features that look, well, quite well suited to tackling alcohol withdrawal.
Like what? What's the key difference?
The big one is its dual action. Unlike benzos, phenobarbital doesn't just augment GABA. It can directly open the chloride channel on the GABA receptor, even without GABA being present.
Okay, so it doesn't rely on the body's depleted system.
Correct. And crucially, it also works on the other side of the equation. It affects the excitatory glutamate system by blocking AMPA and kainate receptors.
Ah, so it's hitting both the inhibitory and excitatory problems, pushing the brakes and easing off the gas.
You got it. That broader mechanism might explain why it often seems to work more uniformly, even in those benzo-resistant patients.
That makes a lot of sense. What else?
Predictability is another huge plus. The pharmacokinetics are much simpler. There's a fairly linear relationship between the total dose you give and the blood level you achieve.
So you can actually estimate the level.
Within reason, yes. Based on the cumulative dose someone's received, you have a decent idea of their serum phenobarbital level. That's way more predictable than with benzos.
That must make managing it feel less like guesswork. If the drug is on board.
Absolutely. And then the real game changer, perhaps, is its incredibly long half-life. We're talking typically 3 to 4 days.
Days. Wow, how does that help? Seems like it could build up.
It does build up, but that's actually the advantage here. You can give doses incrementally, titrating over time to get the patient calm. Once you reach that therapeutic level, the long half-life acts like a built-in, automatic, gentle taper.
Ah, so it wears off really slowly on its own.
Exactly. It provides sustained protection against rebound symptoms for days without needing a complicated tapering schedule or constant redosing. It avoids that roller coaster effect.
Okay, that sounds much smoother.
Right. And the sources emphasize its wide therapeutic index when it's used as monotherapy. The dose range needed for effect, usually somewhere between 5 and maybe 25 milligrams per kilogram total, is well below the dose where you start seeing severe toxicity, which is often cited as over 40 milligram kilogram.
So there's a decent safety margin as long as you're not mixing things.
Precisely. That margin shrinks considerably if you add other sedatives, especially benzos.
And it's good for seizures, too.
Oh, yeah. Barbiturates are potent anti-epileptics, probably better than benzos, specifically for alcohol withdrawal seizures. And the dosing for seizure control is pretty straightforward. You aim for a certain level, often achieved with a total dose around 15 to 20 milligicalograms.
Less risk of causing that weird paradoxical delirium, too, you think?
It seems so. Anecdotally and in some studies, it appears to cause less iatrogenic infusion compared to benzos. And because you generally need lower cumulative doses overall, thanks to that long half-life, the propylene glycol toxicity issue is completely avoided.
And you mentioned you can actually check levels.
Yes, you can measure phenobarbital blood levels. That's incredibly helpful in tricky situations. Is the patient undertreated? Overtreated? Is something else entirely going on? You just don't get that kind of objective, actionable data with benzos in this clinical scenario.
That's a huge practical advantage for troubleshooting.
It really is. Plus, it comes in IV, IM, and oral forms, all well absorbed, which gives you flexibility. 4V is often preferred initially for rapid control in the acute setting.
Okay, one thing that sounds odd is that you said moderate doses don't necessarily sedate tolerant patients much. A 10 milligram dose?
Yeah, it sounds counterintuitive, doesn't it?
Yeah.
But someone who's heavily tolerant to alcohol and is in that hyper-excitable withdrawal state can often tolerate a dose like 10 mg/ml, which might achieve a serum level around 15 mg/ml with surprisingly little sedation.
Why is that useful?
It's a massive advantage because it means you can potentially give a prophylactic dose. You can give a protective amount up front to a high-risk patient who isn't symptomatic yet without just knocking them flat.
Wow, okay. Prevention.
Yeah. And finally, the sources really talk about the potential for simplicity. Phenobarbital can often be used effectively as a single agent, as monotherapy. Things get much more complex and, frankly, riskier when you start layering benzos on top due to that synergistic respiratory depression.
Okay, so lots of potential upsides. How do these sources suggest it's actually used on the ground in practice?
Well, a common strategy they describes starts with an initial loading dose, often around 10 milligrams per kilogram, usually given IV.
And again, that dose shouldn't zonk them out if they're truly in withdrawal.
Correct. In a tolerant withdrawing patient, that dose is unlikely to cause significant sedation on its own. It's really just to get them into a therapeutic range more quickly.
Makes sense. Do you always give the load?
Not always. You might reduce it or skip it altogether if the patient has already received substantial doses of benzodiazepines, because you want to avoid that additive effect. And dosing is usually based on ideal body weight, not actual weight.
Got it. And then after the load or if you skipped it?
Then you titrate with subsequent PRN, or as-needed doses. A strategy that's been validated and described involves giving 130 milligrams DTAT every 15 to 30 minutes.
And you're aiming for a specific target, not just calm.
Right. You titrate specifically to achieve a certain score on a sedation scale, most commonly the RSS, the Richmond Agitation and Sedation Scale. The goal is usually a RASS of 0, meaning calm and alert, or maybe meet a 1, slightly drowsy but easily woken.
RSS, not the CIW score that's often used.
Often RSS, yes, especially in ICU settings. The thinking is that RS focuses purely on the level of agitation and sedation, which is what you're directly treating with the phenobarbital. CIW includes other symptoms like nausea or headache, which might not respond to phenobarbital and could be from other causes. RS is arguably simpler and more targeted for this purpose.
Okay. And is there a ceiling on the total dose, a point where you stop?
Absolutely critical. You must track the total cumulative dose given. The sources consistently emphasize stopping titration somewhere between 20 and 30 milligrams per kilogram total dose.
A hard stop.
It might be described as a soft stop, where you seriously reassess, or a hard stop depending on the specific protocol and clinical situation. But that range is key.
Why stop there? What's the concern?
Two main reasons. First, going above 20-30 milligilograms significantly increases the risk of oversedation and respiratory depression. But maybe even more importantly, if you've given that much phenobarbital, likely achieving a high therapeutic level, and the patient is still significantly agitated.
Then it's probably not just withdrawal.
Exactly. The likelihood that something else is causing or contributing to the agitation goes way up. Hitting that dose limit without achieving sedation is a massive red flag telling you to stop and reevaluate the diagnosis.
That's fascinating. The dose itself becomes a diagnostic tool.
In a sense, yes. If sufficient phenobarbital isn't working, you need to look for other causes of delirium immediately.
Okay, it sounds powerful, maybe more predictable, but obviously any potent sedative has dangers. What are the absolute must-not-miss pitfalls?
Number one, highlighted again and again in these papers, is getting the diagnosis wrong. Specifically, giving phenobarbital, or really any GABergic agent like benzos, to someone who actually has hepatic encephalopathy.
Why is that specific confusion no bad?
Because hepatic encephalopathy is thought to involve excessive GABA signaling in the brain already due to the liver failure. It's like the opposite problem of withdrawal. Adding phenobarbital can dramatically worsen the encephalopathy, potentially leading to deep, prolonged coma. Severe liver disease or active hepatic encephalopathy is a major contraindication.
Wow. So confirming it's withdrawal and not hepatic encephalopathy is step 0.
Absolutely non-negotiable. Another huge pitfall is simply losing track of or ignoring that cumulative dose limit we just talked about. Going over 20-30 milligicol again increases risk and, again, strongly suggests you're treating the wrong thing.
And the mixing with benzos.
Yes, that synergy. Combining phenobarbital titration with ongoing benzodiazepine usually significantly increases the risk of respiratory suppression and makes the response unpredictable. The sources strongly advise against it. Basically, choose your primary strategy. If you're titrating phenobarbital, stop the benzos. Don't try to titrate both at the same time.
Pick a lane and stay in it.
Pretty much, yeah. Another trap is misinterpreting the symptoms you're treating. Are you using phenobarbital for true withdrawal agitation, or are you inadvertently treating something else?
Like what?
Like non-alcohol-related delirium, or NARD. Maybe the agitation is driven by pain or underlying psychosis or even just personality factors.
Yeah.
Clues it might be NARD could be agitation without the autonomic signs of withdrawal, like high heart rate, sweating, or symptoms persisting beyond the typical withdrawal time frame, like more than 2-3 days, despite getting what should be an adequate phenobarbital dose.
And if it is NARD?
Then phenobarbital isn't the answer. You need to find and treat the cause of the NARD. That might involve different medications entirely, maybe antipsychotics like haloperidol or alpha agonists like dexmedetomidine. More phenobarbital will just sedate them without fixing the root problem.
Any practical issues mentioned, like getting the drug?
Yeah, logistical hurdles can be a problem. If it takes the pharmacy 30 or 45 minutes to send up each PRN dose while the patient is climbing the walls, it really hinders effective, rapid titration.
So what's the workaround?
Things like giving that initial loading dose helps buy time. Also, having phenobarbital vials stocked directly on the unit, or protocols allowing nurses to draw multiple doses from a larger vial ordered up front. Streamlining access is key.
Any other groups needing special caution?
Patients with severe cirrhosis, even without overt encephalopathy, they metabolize drugs differently and are at higher risk. You'd likely use lower doses and have a lower cumulative dose threshold, maybe keeping it under 15 millikilograms.
What if you're really unsure about the diagnosis at the very beginning? Is it withdrawal? Is it something else?
One interesting approach mentioned is using a small test dose of a very short-acting benzodiazepine, like IV midazolam.
How does that help?
Well, if a tiny dose makes the patient significantly sleepy, it suggests they don't have high GABAergic stack tolerance, making severe alcohol withdrawal less likely. If, on the other hand, they tolerate that dose with little effect, it points towards high tolerance, supporting the diagnosis of withdrawal, and might make you feel more comfortable proceeding with a longer-acting agent like phenobarbital, if that's your plan.
A sort of diagnostic challenge.
Interesting.
Okay, moving beyond just the phenobarbital or benzos, what about essential supportive care? What else is crucial?
Oh, absolutely. High-dose 5-phenethylamine is a must. The sources recommend 500 milligrams 3 times a day initially. Wernicke's encephalopathy is common, can mimic withdrawal, and needs aggressive treatment. You treat presumptively.
Okay, thiamine. What else?
Keep a very close eye on blood glucose. Hypoglycemia is common in alcohol use disorder. And in malnourished patients, be mindful of refeeding syndrome when you start nutrition. Basic supportive care is foundational.
And what about prevention? Can you actually stop withdrawal from kicking off in someone high-risk admitted for, say, pneumonia?
Yes. The concept of prophylactic phenobarbital is discussed. Giving a moderate cumulative dose, maybe 10 to 15 millicilligram total, to patients identified as high risk using tools like the Paulev score before they develop severe symptoms.
But only if they don't have contraindications.
Exactly. No active severe withdrawal yet, and critically, no contraindications like potential hepatic encephalopathy. It's about intervening early in the right patient.
Got it. Okay, let's shift gears slightly to the evidence. What do these studies you looked at actually show? How does phenobarbital really stack up in comparisons?
Well, these sources review several key studies. There's a retrospective ICU study by Ox and colleagues. They found significantly lower rates of intubation in patients treated with phenobarbital monotherapy compared to their historical controls who got mostly benzos.
Lower intubation with phenobarbital. That seems counter to the usual fear.
Right. And importantly, they noted that when patients in the phenobarbital group did get intubated, it was often before the phenobarbital was started, or for unrelated medical reasons, not because the phenobarbital itself caused respiratory failure.
That's a really important nuance.
It is. Then there are other retrospective comparisons. One from Mass General by Nasavik et al. found phenobarbital protocols performed similarly, maybe even slightly better than their benzo protocols, despite the phenobarbital group often having sicker patients. And it showed clear benefit for patients who had failed benzotherapy, the so-called benzo-refractory group.
So it rescued patients when benzos weren't enough.
Seemed to, yeah. Another study by Nelson and colleagues in Colorado also found their phenobarbital-based protocol was safe and effective, with outcomes comparable to their previous benzo-heavy approach.
Okay, so generally positive or comparable results.
And one study I found particularly compelling was by Waldy and Fan. They look at using oral and IM phenobarbital monotherapy, not even IV, in psychiatric inpatients, a group often with high substance use risk, but maybe not critically ill needing an ICU.
What did they find?
Really impressive results. They managed these high-risk patients effectively with just oral or IM phenobarbital and had 0 transfers to a higher level of care and 0 intubations in their entire cohort.
0 intubations in that group. That's striking.
It really is. It strongly suggests that maybe the high intubation rates seen in some ICU studies are driven more by the patient's underlying severe medical problems rather than being a direct consequence of the phenobarbital treatment itself.
Interesting perspective. So what's the overall trend from these studies?
The overall picture painted by these sources is pretty consistent. Phenobarbital appears safe, it's effective, it does not seem to increase the risk of intubation compared to benzodiazepines, and might actually decrease it. And having clear, structured protocols seems crucial for allowing clinicians to use it safely and effectively, often enabling them to give the higher, more effective doses when needed.
And you mentioned some studies that didn't show a big difference, might have underdosed the phenobarbital.
Yes, that's a point made in several sources. Some studies that concluded phenobarbital was no better than benzos might simply have used phenobarbital doses that were too low, never achieving adequate therapeutic levels to really test its potential.
So it's not just using the drug, it's using it the right dose, the right titration within a clear plan.
Precisely. That's the strong message coming through from this material.
Okay, wow. This has been quite a deep dive. Trying to pull it all together then. Phenobarbital seems like a really potent tool for alcohol withdrawal. It's got these clear pharmacological advantages over benzo's predictability, that dual action on GABA and glutamate, the super long half-life, making things smoother. And the evidence you've walked us through suggests it's safe, it's effective, maybe even better in some tough situations like benzo resistance.
Yeah, the data is certainly pointing that way.
But it demands real care.
Yeah.
Getting that diagnosis absolutely right is paramount. Respecting those dose limits is non-negotiable, and being incredibly careful about mixing it with benzos or using it in liver disease.
You've nailed the key takeaways. Hopefully, going through this gives you, the listener, a much clearer, more nuanced picture of this really challenging clinical scenario and why phenobarbital is having this sort of resurgence. It's about the drug, yes, but just as much about the diagnosis and the structured approach to management.
Absolutely. And maybe just one final thought to leave you with. Given that the big shift away from barbiturates towards benzos back in the 70s wasn't apparently based on rock-solid comparative evidence, and now we're seeing evidence supporting a return towards barbiturates like phenobarbital, what does that whole historical cycle maybe tell us about how medical practice evolves, and perhaps the importance of continually critically questioning our standard approaches, even the ones that feel really well established, as new evidence comes to light? Something to think about.